Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Welcome to the Low Carb MD podcast. We have a super exciting guest, somebody I've had the chance of sharing a couple meals with, seeing at really amazing conferences with, and we're going to be both involved in a local screening of the Cholesterol Code documentary. This is somebody who I've turned to for advice and somebody I've turned to really as a mentor to me. Giving me some sort of guidance on medicine in general. His name is Dr. Alan Schaffer, and he went to Duke undergrad, went to Tulane for medical school. He did his residency at Memorial Hospital. He did his fellowship at Albany Medical, another fellowship at Montefiore. He is obesity medicine certified, one of the first obesity medicine certified areas in the Hudson Valley area. He is sleep medicine certified, one of the early adopters of sleep medicine, also in the Hudson Valley area. He is also a pulmonary and critical care doctor on top of being an internist. And he's a Society of Metabolic Health Practitioners, metabolic practitioner. I probably missed a number of his accomplishments, but he's actually in the New York area, not too far from me. We've shared steaks, we've shared stories, and he's just a really amazing guy, and I'm so grateful for him to come on the podcast, talk about his story, and also talk about his impact on obesity medicine, sleep medicine, and metabolic health, but also discussing the fact that we're both trying to get this cholesterol code screening done up in the Hudson Valley here and in New York, where we're both doctors. So that's a long-winded introduction. Dr. Alan Schaffer, can we go by Alan and Tro? Is that okay?
Please, absolutely.
I'm so happy to have you here. I know Brian's going to be pissed that he wasn't here, but you know, you've graced us on a Sunday morning, and I know where Brian's at, so he's just going to have to be okay missing this one. But thanks for coming on, and thanks for telling people. Thanks for being an advocate for 20 plus years in this space before it was called metabolic health.
Yeah. Well, thank you very much for having me. And being an advocate, just it almost happened by sheer accident or chance. I mean, I was always a skinny kid growing up, okay? And when I was 18 years old, I had back surgery. And after the surgery, all I did was sit around and eat. And what would I have? Big subs with pastrami. Little did I know it wasn't the pastrami, but it was the sub bread. And spaghetti with meatballs, like every day. And I gained like close to 40 pounds in just a matter of months. My pre-op weight was at 6'2", 185, and I ballooned up to like 225, 235. And I stayed there from age 18 to 48. And I figured, okay, I had a beer belly at the ripe old age of 18. And I figured this is how it was, because in medical school, as you know, we're taught not to bother with weight loss because it's futile, right? Of course, the advice was wrong, but that's another story. So I'm 48 years old. My son has a play date, and his friend's mother comes to pick him up and says, "Alan, I want to show you something." So she shows me this PowerPoint about Medifast, and I was like, "Wow, that looks like it may really work." And I didn't know anything about any of this stuff. So I had gained even more weight at that point. So I said, what, let me try this and see. So I tried it. I lost 14 pounds in 14 days. I felt invigorated, I felt just terrific. I haven't felt that good in ages. And I was active. I was playing volleyball. And So I decided, well, I'm a sleep doctor. I'll try it with some of my patients, and because so many of them need it. And in fact, patients were doing great. And that's when I learned about, you know, I initially thought it was calories in, calories out, of course. But when I started going to conferences, I found out there was even a specialty on what they used to call bariatric medicine. It's now obesity medicine. So I got certified in that and really understood that it really is about carbohydrates and less about calories in, calories out. So I went forward with that, and then I was doing the obesity medicine thing, and then I found out about SMHP, and I said, well, this is it. They're really looking at the physiology, at the cause, and it's like, these are my people, And so, yeah, it's great. I'm more than glad to be an advocate for the science and the people that are really looking at the true science rather than listening to the dogma of years gone by. So, and of course, having had, so I ultimately lost, that weight. I went back to my 185, and I've been 185, low 190s ever since in the last 18 years. And so this is not just something I believe in science, it's something that I've experienced in my life, in my heart. And that's the kind of thing that drives so many people in the low carb space, because we see what it's done for us. There's nothing more powerful than personal experience. So I'm really quite passionate about the importance of really doing the work that we're doing. And I love, Tro, the work that you're doing. Um, but it's so when I did my pulmonary fellowship in Albany, I actually did just a week of sleep medicine, an elective. And then I joined my practice down in Orange County, New York, pulmonary critical care practice. And the hospital came to us and said, hey, we're looking to start a sleep program. Nobody's doing it in the county. Anybody interested? I said, well, I did a month. So I said, sure, why not? And so we started the first sleep center in Orange County, New York, and I became very busy in that. And then, so I was seeing tons of patients, and then I lost the weight, and I basically took all my sleep apnea patients, those that were overweight or obese, and I introduced them to the weight management and the metabolic health aspect of my practice. And the synergy is just, Tro, if I often say that I don't think I could have designed a practice for myself any better than what I'm doing right now, And the other cool thing is that in 2023, 3 years ago now, I had the opportunity to leave my practice in critical care and pulmonary, and so I have left all that behind, and now I'm going up to St. Peter's in Albany and practicing purely outpatient sleep medicine, metabolic health, and obesity medicine. So again, it's the perfect practice. And it just so happens that where I'm working is the same sleep center where I did that elective back in the early 90s. So it's all, it all comes around. And in this case, just a beautiful way,
One of the themes, like when I talked to you, I immediately I got the feeling of it's just pioneer, right? Pioneer. People don't understand. It's tough to be courageous as a doc. Like, it's not an easy thing, at least intellectually, scientifically. It's just but like, here you are pushing the forefront. You're a pulmonary critical care doc pushing into sleep medicine at its infancy, right? Yep. And then pushing into obesity medicine at its infancy, and then bringing that to your community, and bringing each one of these, and now you're bringing metabolic health to your community. Gosh, to the point where you and I are working together now to bring a documentary about cholesterol to our community, which I get this theme of just a lot of empathy that I've seen again and again just talking with you, and
thank you.
A lot of not being afraid to sort of be a shepherd, I guess, right? Like be an intellectual shepherd, right? It's hard and I think lonely to be at the front for so long. And
Yeah.
I'm curious, has it worn on you, or what's been the feedback like
Um,
back then when you were, going into obesity medicine? I'm like even that was controversial. I know people were
yeah.
like, "This is what do you mean obesity medicine? Is that even real? Like you're a critical care doc,
Right.
go do bronchoscopies, and
Well,
then you bring sleep medicine, same thing, right? Like what do you mean sleep medicine, right? Like that's a like I'm
yeah.
imagining this was like always at the forefront,
Yeah.
Um,
It's funny because I don't feel like a pioneer. I'm feeling like just I was served the opportunity to work in these fields. And I found sleep medicine very interesting. I mean, one of the things about pulmonary critical care is that we're getting patients on the tail end of their disease. They've been living their life. Many of them have been smoking. Most of them have been intoxicating themselves with carbohydrates, right?
yeah.
And we see the results. And these are the people I see in the ICU, and these are the people I see in the pulmonary lab that they can barely breathe. And what struck me, and really one of the things that drew me to sleep medicine first, was that I could actually make a real difference before it's too late in these people's lives by helping them sleep. I mean, sleep apnea is such a big problem in our society, especially as we get larger and larger. And by treating them, number one, they feel so much better. Number two, I'm actually improving their health, their metabolic health, and their longevity. And it's just so gratifying as opposed to holding the hand of the COPD patient, as they're taking their last breath, which I'm glad to do, but it's a different. I feel like I'm making more of a difference. And there have been just a few patients I've seen in the ICU. I After I started losing the weight, I saw a lady weighed 300 pounds, and she was in the ICU, and she was intubated on a ventilator, and she had respiratory distress syndrome, and she had heart disease and lung disease. And for some reason, it just struck me that, oh, if only she was being given advice that would have helped her long before it was too late. So that's one of the things that really moved me again towards the sleep medicine. And then when I lost the weight and felt like $1,000,000 and started practicing obesity medicine, metabolic health, so much more that I feel driven, to really make a difference. It's making a difference in our patients' lives that, we all want to do as doctors. But yeah, you talk about we're fighting against the status quo and the dogma. Absolutely. I mean, one of the reasons I go to all these conferences all the time just to fight against the damn gaslighting that we're all subject to. As much as I know the science, it's just when so many people just come at you and come at you, it's it's really
It's
rough,
exhausting. I
Yeah.
want to talk about pulmonary medicine. I want to go back. I know you focused on
Yeah.
obesity, and there's something about pulmonary medicine that's unique, and it's a perspective that you just said to me that sort of lit the match in my head. We all know the importance of our diet on our overall health, and I think increasingly we're becoming aware of chronic exposure and how it affects us.
Yeah.
Glyphosate is in the news,
Hmm.
and a lot of these things are in the news. And I'm thinking to myself, okay, like, all right, so you finished training in critical care pulmonary medicine in the 90s, right? Is that right?
I
Or
did. Yeah, I finished critical care in '92. No,
92,
no, '94. Yeah.
94. Okay,
Hmm.
so you're in pulmonary critical care doc, and I'm thinking to myself, okay, you're in the ICU. Back in the 90s, the pattern of people who are sick, right? Obesity, high triglycerides, right? Like every single person, manage their sugar in here, manage their blood pressure, right? Like, get them in, and you probably saw the pattern right away. High sugar, and adiposity, central adiposity, meant this person was going to be critically ill. Or maybe the flip side, they were cachexic, really malnourished, and they would get really ill. Probably a mix of the two, right? But like inside is starving, basically. So I'm guessing you made that pattern, right? You made that pattern. You see it, right? Because you can't go to an ICU and not see that happen, right? It's either the frail and the cachexic, the old sarcopenia and elderly, or it's, younger with metabolic and chronic disease, right? But I'm thinking the other thing that pulmonary critical care exposed you to was the chronic exposure. I mean, all the chronic exposures, that's the major field in medicine where we learn about chronic exposures. Silicosis, right? The mining dusts, right, that we breathe in. They get the TB, the cancer, right? The asbestosis, the shipyards, the brake lining, right? And now they're getting disease later on. Coal dust, right? Coal workers, lungs, right? Tobacco smoke, radon, disease from radon from the basements and the residential soil, and they're just getting trapped and not getting aired out, right? And all the organic dusks, beryllium, right? Like beryllium, like all cotton dust. You have all of these exposures that we learned about. I remember being an internist learning about for my board exam, and we're looking at the specimens of the cells of the lungs under microscopes, metal dust, right? And the pesticides. But pulmonary critical care was and I'm thinking about this, was a foray immediately into chronic exposures and metabolic health, and I mean, maybe, do you think that, and I know this is a little out there of a question, but do you think that played a factor in how you viewed chronic disease, like that bedrock of looking at medicine in this way? Like, what has this lung been exposed to? What are they breathing, right? What has this vessel been exposed to? What have they been eating, right?
Yeah. I'll answer that by saying certainly not consciously. Might it have subconsciously planted a seed in me? Maybe. But to be honest with you, from 94 when I went into practice till 2008 when I was losing the weight, and even probably for a while beyond that until I really got into understanding metabolic health, I was just going through the motions. Yeah. And I would not ask any questions, and I would not witness any patterns. I wouldn't see, oh, this person did this. Is this something we can impact on a societal level? No, I didn't do any of that stuff. I just when I saw somebody with asbestosis, okay, did they have pleural disease, parenchymal disease, nodules, lung cancer, mesothelioma? And it was just, that's where I was. And that's how we're all trained, and that's where I was going. But it was this personal experience of losing that weight and feeling so much better that it literally woke me up, Tro. I mean, it did. But before that, I was pretty much, asleep on my feet, in terms of an awareness level. So I don't know if that's the answer you were looking for.
No. I was no different, right? I was a 350-pound board certified, internist serving as my chief resident, year, and here I am asleep at the wheel. Can I ask you a question? So, as you've sort of woken up, how has this impacted the way you practice medicine? Because, a lot of what we do is structured by a system, right? Of seeing people face to face, billing the insurance for the occurrence. How have you navigated, actually practice, like you had this light bulb moment?
The mechanics of it. Yeah. So typically patient comes to me, probable sleep apnea, snoring, witnessed apnea, daytime sleepiness, whatever. And I talk to them for about 40 minutes about, how they're sleeping and various issues. I said, we're going to do a sleep study. Okay. I tell them why. I go through the pathophysiology in layman's terms of sleep apnea. because education is so key in terms of getting patients to understand and then adhere to therapy. And then at the end of that, after I said, we're going to go schedule the sleep study, okay? And then I'll say, by the way, I'm also board certified in obesity medicine, and I'd be glad to work with you if you'd like on weight management. So, and those are the exact words I use. That's my script, right? And notice I don't say you need to lose weight like so many people will do, which just leads to more fat shaming that so many people suffer from. So it's important to empower the patient to make it their decision. And many will show a lot of interest. Many who I'll see, they're type 2 diet, like just yesterday or Friday, just type 2 diabetes on insulin, on Jardiance, and all these things on a statin, and just pushing their metabolic health to get worse. And I want to say, I want to help you with this because you're somebody that can really, really help. But I put it on them, and I did. And she said, okay, thank you. And that was it. And I'm okay with that because it's got to come from the patient. So how do I do it? If for patients that are interested, I'll say, okay, I'm going to draw some blood. So I'll do a home IR, A1C, and all that stuff. And the follow-up appointment to go over the sleep study results will double as a new intake weight management metabolic health appointment. So I'll go over their results. I'll say, hey, you have sleep apnea. Let's get you the CPAP. Do you have any questions? Okay, good. Now let's talk about weight. And then I go through the whole dietary history, and then I will talk to them about the carbohydrate insulin model of diabetes and obesity, and explain why calories in, calories out doesn't work for so many people who are insulin resistant. And again, it's the education point I think is so important. And so I do my follow-up visits, so I'll see them every month to see how they're doing with their CPAP. So I'll basically put it under sleep apnea. And that's how I navigate the system. So it's sort of naturally built in for me. And if you have any ideas about how I could do it better, I'm certainly, I'd love to hear it. But it's working pretty well.
Well, I know exactly how to do it. Give every person our app. We should get you our app for free, and you just give every patient that walks out our app, so they have a community and it's sort of a program to follow. But I'm just thinking what you're doing is you're basically assessing readiness to change.
Yep.
And then those who are ready to change, focusing your time and effort on them, which is the only way to do it.
Yeah.
I tell the docs out there all the time, like, just put a sign in the room and don't even say anything that says in big letters, like, do you want to get healthy? Right? Like, ask me about it. Right? Ask me about how to come off your medications.
Right.
And then you don't even have to break, if you think that the subject is too charged to talk about, you don't even have to talk about it, you just put a big poster.
Right. I actually I've thought about doing something like that or have a postcard for patients, but I just like the face-to-face, in person. And like I said, just offering my services rather than making it threatening. Because I've had, a lot of times I'll bring it up and I'll have a patient do the crossing their arms thing, and so you can tell that they're not there yet. But I also love seeing the look on patients' faces when they have hope in their eyes. It's just so amazing.
I think a lot of places where people struggle, and I think I've seen this phase of sort of people giving up on helping, where what they did was they just go and they have a solution and they evangelize that solution, and they get negative feedback from people because they're evangelizing a solution at a time when the patient's not ready. And so, of
Right.
course, and with a highly emotional thing, right? Whether it's smoking, whether it's food, whether it's alcohol, it doesn't matter what the stress reduction mechanism is, right?
Hmm.
If you are going to take that away, the visceral response is, what are you doing and why? And why are you taking this away from me, right? On a subconscious level. So the docs who are out there evangelizing because they want to help, right? They get faced with immediate punishment
Hmm.
from poor responses. So they're being psychologically operated on. It's like a both
Hmm.
ways, right?
Yeah, yeah.
Right. And they're getting negative feedback because they're like, well, I just want to help. And now I'm being punished. Like, I'm just going to stop doing this because I can't do it because, patients got to want it. Right. And then they shut off. Right. And
So if you're an oncologist, are you going to stop taking care of a patient because they don't want chemotherapy?
well,
I
many of
mean,
them do that. Right. We're going to kick you out of our practice if you don't do what I say. And so
yeah,
that's the other response, with
yeah,
docs. And I know you and I have been seeing this. You've seen it a lot longer than I have. So it's this either learned helplessness or
mm,
authoritarianism, and there's no sort of middle ground, right? There's no middle ground. They can't sit with that uncertainty and say, well, what can I do to get better,
yeah,
right? Which is hard, right? Like, how can I make my message better so that they can receive it? How can I assess who's ready so I'm not harmed emotionally when nobody's listening to
right,
me?
right.
Right. And so you're doing this like effortlessly, but I think we should bring it out and talk this through because, I've seen too few people be able to sit with the discomfort of
Yeah,
working with somebody for years, maybe until they're
hmm,
ready, and then they wake up and you strike while the iron's hot. So
yeah,
I'm curious because you have these sleep patients
yeah,
seeing you for CPAPs for a long time.
yeah.
And so I'm curious to hear of those late bloomers, and how you handle that life cycle.
Okay. See, that's knowing that there are late bloomers, as you call them, is what keeps me motivated to keep offering my services because I'll either be giving them something they're ready for, or I'll be planting a seed. So when they are ready, they'll come back to me. One of my, this is from my old practice. This is, boy, how long ago? 20 years ago. This guy, his name is Larry. I've been his internist, basically, hypertension, diabetic, and obese. And I started doing my Medifast thing. And I'm like, hey, Larry, I have this program for you. And I had just started it then. And I said, I explained it to him a little and I said, it's really helping me. I said, what do you think? I said, I don't know. I'll let you know. Okay. So he comes back in 3 months for his next follow up. And he says, Doc, that weight loss program you were telling me about, tell me more about it. And I did. And he actually lost a good bit of weight. And I don't remember how or if we deprescribed any meds for him, probably did, but it made a real big difference. And he since moved out of the area. But before he left, I said, Larry, something's been bothering, not bothering me. I just didn't know the answer. And I said, when I first told you about my weight loss program, you just you blew me off. You poo-pooed it. And then you came back and you're like, well, maybe I can do this. And he said, well, to be honest with you, the difference was I looked at you and you were just as overweight as I was. So why would I listen to you? So there's going to be a big part of that too. Um, but again, it was just being open to the idea that, maybe somebody will come around, and it's just taking your damn ego out of the equation. Who cares? I'm not here to help somebody so I can get a pat on the back or, whatever. I just want to help people, but I want to help people who want to be helped. Otherwise, we're wasting our time for sure. And we're not doing the patient any service. So I'm just offering my services, and whoever takes it, takes it. And I've always felt that way ever since I started this this work. And the other thing is when you come at patients with that attitude, that you're not trying to sell them something, and you're not being dogmatic and telling them what they need to do, but just offering it. It's just, people get it. I haven't had anybody say to me, "You're just trying to sell me something," you know?
100%. One of the things that I've done this year, which we did a little bit differently, is especially the weight loss world, they've been sold something again and again. First it was fen-phen, then it was a drug that was pulled off and pulled off and pulled off.
Mhm.
Weight Watchers again and again and again. Finally, they went
Right.
bankrupt. It wasn't about hormones, right? I mean, the first iteration of it's nothing to do with hormones. Obesity has nothing to do with hormones, and then all of a sudden we have a hormone that helps people lose a lot of weight, and now it's like it's still about calories, and that's why we're giving you a hormone. Like, it's just conceptually makes no sense. But so the
Nope.
gaslighting and
Mhm.
being sold the supplements that they've been sold, like take this to lose weight, go lean, go more, go less, hydroxycut, take these herbs, do the B12, the HCG, that you've seen all the fads come and go.
Yeah.
So I was thinking to myself, and that this year is going to be different. So we, in our practice, we put together an idea of like, okay, how do we guarantee people? How do we align our interests with people who are struggling with weight out there?
Mhm.
And what we did was, we cannot give in New York State. You can't give a medical guarantee. You cannot say you can't give it, right? Because it's the truth. Like, you
Mhm.
can't guarantee anything. You can't say
Right.
you will lose 43 pounds, even though
Sure.
that's what Ozempic says. Right? We can't say it. So what we did was we gave a service guarantee. If you keep your blood sugar stable with a variability under 11%, if you every time you measure your ketones, you make ketones, and you came in with a BMI of over 40 or an A1C over 7.5, and we don't improve either of those, you do not have to pay for 6 months,
Right.
right? So, what I've
Mhm.
tried to do is like take out, because you talked about being a victim, right? A lot of these people have been victims. They don't want to be sold something to.
Mhm.
Uh, but interestingly, I've had to embrace the other way. How do we sell something to people? How do we give
Ideas.
them? How do we give them like a? How do we sell them something and align our interests with their interests? Like, if I don't help you, I'm gonna suffer.
Right.
I'm gonna suffer financially,
You have skin in the
right?
game.
So I think I don't know. I want to hear your thoughts about this. Am I crazy, Alan, to do
I
this? Am I crazy to do this? What do you think?
I
Sorry to make this about me, but I go to
no,
you for
I'll
mentorship.
talk about you
You know,
as much as I can.
I go to you for mentorship. So
Oh,
sorry to make
please.
this about me.
No, I think what you're doing is brilliant, because it goes along with the theme of empowering the patient, right? Isn't that what you're doing by this? It's not just the financial. You're basically telling the patient it's up to you. You're telling the patient that, I am working with you rather than taking money so you can try another thing that may or may not work. I think this is really empowering for patients. When you said that, I was like, gee, there he goes again, another brilliant outside the box idea. And yeah, I love the thought. I don't think you're crazy at all.
Yeah, I
I
mean,
think,
I think we have
yeah,
to sell to like, what does the patient want?
yeah,
Right? They want to
mm,
have faith. They actually don't want to be sold to, right?
right,
Like, don't sell me something that's not going to work, right? But they would pay for something that'll work,
right,
right? So how do we go away from the occurrence model of medicine, which is just like,
yeah,
come see me, get me a paycheck, do what I ask, to you know what, come see me, and I'm putting where my money where my mouth is a little bit, and I'm gonna, you know, and I actually do this in my own sleep practice too, and I bet you do this. It's like, just try the CPAP.
Hmm.
If you feel better, you know, if you feel better, like you'll know, you know, like
All the time.
just
All the
try
time.
it,
Yeah.
right? I'm curious, how do you, you know, nobody wants to be Darth Vader, as my patients say, but
Right.
how do you overcome some of these hurdles of like the trust?
Okay. First, for my sleep or my metabolic health patients or what?
Yeah, I do
Or
all
all
of
of
them.
it?
I want to learn.
Okay. Okay. So first of all, the Darth Vader thing. I thought you might bring that up. Hold on.
Yeah. Oh my God. So if the listeners, right, they have to
So
see that,
can't
they
hear.
have to see
So
this,
this
right?
is my CPAP mask. Okay. So this, and I showed this in the grand rounds that I did too.
Yeah.
Um, so it just sort of, see if you can see it. There's just an opening here. There's nothing that goes inside the nose. Okay. It just cushions the nose. It's called a nasal cushion. And the tubing, which is often right in your face, comes in up here on top of the head, and this little piece swivels,
So guys,
so you can
he's
get the
showing,
tubing out of the
if
way.
you're a
And there's
listener,
just one Velcro strap that
he,
holds it in place.
he's
So
showing a
I've been using
minimally,
this mask for the last 10 years since it
guys,
came out,
if
and it's just
you're
the best.
if you're listening on the podcast, he's showing something that's like what it's basically just like a little piece of tape around the nose, and
Yeah.
it doesn't look like much at all.
It's a little more than wearing oxygen, but not much, you know.
And do you show your patients that, and does that help them sort of
Oh
like,
yeah. Oh
yeah,
boy, I can always tell. I like to, offer you CPAP at this time, and you can always tell the look, right? Ooh, yeah, the dread, and because they've seen all the commercials about the hypoglossal nerve stimulator, and all they show is the Darth Vader look, and you don't want that. So that's where they're conditioned, right? So I show them that mask, and I just show it to them just like I did to you. I said, "Oh, I had a lady just the other day. Oh, I could try that." I said, "Okay, and we'll see how you do."
can you, so let's walk through it. Let me describe a patient, like the worst patient with sleep apnea that I knew. You know, I
Mhm.
had a patient who had to lose a lot of weight, a young gentleman, had to just drive his kids around. And every time he would come into the office, first of all, his neck was really big. He had a
Yeah.
lot of weight to lose. He wanted to get
Hmm.
better. He
Hmm.
was so tired. He just couldn't keep his eyes open.
Oh,
Literally, like you'd have the MA, the medical assistant, come out of the room, and when you went in 2 minutes later, he was already asleep, you
yeah.
know, and you just look at him and you could tell like by his eyes, like there was
Yeah.
bags under his eye, he couldn't sleep, and he would tell you, I feel miserable. I feel like I'm
Yeah.
not getting help, and his blood pressure would be so high, and it doesn't matter what medication, what he did, it
Mm.
wouldn't come down. And then you go and you test, and you see all throughout the night he's basically being choked by his own tongue.
Yeah.
And so I want you to describe like the shift that would happen. Like maybe describe that patient's experience in more detail. If they have sleep apnea, they're listening to this. They have metabolic disease, and how would it feel like that I didn't describe? And what happens after they give this a shot? Like maybe tell people, you know, the people who adopt it and
Yeah.
they're responders, what should they expect to experience?
Yeah. So you described it pretty well. The other thing is that most people work for a living, and they find themselves falling asleep at work in front of their computers, and their boss is saying, "Why are you falling asleep?" And there's that, there's stress, there's having to drive to and from work when you can't stay awake. I mean, this is really, it gets to be scary, not to mention the issues surrounding your health, the metabolic health and its risk of cardiovascular disease. You put obstructive sleep apnea on top of that with the poor sleep quality plus the oxidative stress of the intermittent hypoxemia, right? Lowering of the oxygen. And that's just, it's just the recipe for heart disease, right? So there's a real metabolic thing too. But yeah, a lot of people are just, have these experiences. And so I'll talk to them about it, and I'll somebody like you're describing, if I'm going to order a sleep study, I'm going to see if we can get them on top of the wait list, because we're for an in-home sleep study, we're just a couple of weeks, but for in lab, we're about 2 months. So I might do an in-home just to get them going. And then I'll bring them back quick just to try to expedite everything. And I'll talk to them about the CPAP. And I'll say, what many of my patients experience is that, they're a little reluctant for CPAP. I don't want to wear that thing. And I'll tell you, Tro, this is how the conversation goes. Gee, doc, I don't think I can wear that thing. I said, well, maybe you can, maybe you can't. Would you just try? All right, I'll try. So they come back after using the CPAP for a couple of months. They say, hey, doc, I don't think I can sleep without that thing. So it's just like, I wish I had a nickel for every time I had that conversation. So try it. There's no harm in trying it. And I hear the term life changer several times a week. And it's, it will make a difference, and it'll help you sleep better and wake up, and literally wake up in the world. So all these things that, difficulties staying awake driving, that's going to go away. Falling asleep at work, that's going to go away. Sometimes it may take a little bit of time, depending on how you acclimate to the CPAP, but often it's like, it's the effect is immediate. So it's like not getting enough sleep for a period of months or years, really, lifelong, and then all of a sudden finding out what it's like to sleep well. And it's just, it's in a religious epiphany, I guess. It's just, wow. I would highly, and I experienced that when I started using CPAP.
Yeah, the other thing I'm thinking is it's insidious, right? So I think some of the skeptical nature is, as you gain weight, as the tongue gets a little saggy, as the, whatever it is, the symptoms get worse and worse, and you're not cognizant of it. You're just kind of like the fatigue increased over years, and the poor concentration increased over years.
Yeah.
And then, I had somebody with the AHI, which is, one of the measures I guess we look at on sleep studies, and it was like, I don't know, 120 or something like that. It was just, which we both know means this person's not living, right? They're not living.
They cannot sleep and breathe at the same time, essentially.
Yeah. And then, that's the person you put them on CPAP, and all of a sudden air is being sort of rushed in, and the response, I remember it, he's like, I have my life back.
Yeah.
It was literally within like 2 days. He's like, I have my life back.
That's so cool.
And then he went off to lose a ton of weight because he had energy, felt good, and eventually came off the CPAP.
That's wonderful. That's amazing.
And but can you talk a little bit about the other aspects? There's a lot of alternative thinking, and with sleep apnea. The jaw extenders. I think people don't want to wear a device, and how effective are those? And then, mouth taping. I even had a patient who bought a device that's a weight that he puts on his tongue. It's like kind of suctions on the tongue, and it makes the tongue like, are any of these effective?
Sometimes it might be. I mean, that's called a tongue retention device, and they've been around for a long time. And there are some of these things you can get online, actually. So the CPAP, and I always emphasize this to the patients, it is always the first line therapy. It is always the first line therapy. There is no reason to at least try CPAP unless if it's a financial issue, sure, possibly. But from a clinical standpoint, it's always the first thing, because it's the one that's going to work better than most other modalities, and it's something that's reversible as opposed to doing surgery on your upper airway. And it doesn't take that much time to get an oral appliance, which for people who sort of have my anatomy, let's see if I can, you see my recessed chin here?
Yeah.
Okay. So the chin being the tip of the mandible, which is attached to the tongue. So for me, my sleep apnea is because my tongue is too close to the back of the throat. So these devices, there's an upper and a lower, and you advance your chin to open up the airway behind the tongue. So somebody with my facial anatomy, that is a viable therapy. But not everybody. There's also the hypoglossal nerve stimulator, the implant that people ask me about all the time. And that's also a second line therapy. It's not for everybody. And the unfortunate thing is that the higher your BMI, statistically, the less likely you are to benefit from that implant. And the doctor that I use up in Albany, she would, they do like a simulated sleep endoscopy to see what the airway does. And there are certain patterns that tend to, indicate would it work. But again, she will never entertain the idea if the patient just doesn't want to bother with the CPAP. She always insists on CPAP first. Again, even though it might be costing her the benefits of doing procedure financially, but she's not that way at all. She's patient-centered. And it's just the best therapy. There are upper airway surgeries where you cut out part of the tongue and reattach, all sorts of things. The mouth tape is something that's new. There's been, actually, I didn't know much about it when I was doing the grand rounds. Mark Cucuzella said, Alan, there's a study out of China where they had mild sleep apnea patients with mouth tape, and they did pretty well. So I pulled that study, and that might be useful for some. It's not recommended by the Academy because they're worried about pretty much airway obstruction and bad things happening. But I think on the selected individual, that might be something. But again, as I always say to patients,
because this is like hot right now.
Yeah.
I didn't read that study. So can you tell me a little bit about just, that study? And mouth taping is sort of made it into the mainstream. Yeah. So what's the idea? I just want to understand.
So many people are what we call obligate mouth breathers because they have nasal obstruction, right? So they typically breathe through their mouth, and they're also more likely to have sleep apnea just because the overall resistance of the upper airway is by definition higher. The idea of the mouth tape is to change them to obligate nasal breathers. And the idea is if they only have mild sleep apnea, that can actually help them expand their nasal passages. That's how I understand it. That might be not be perfectly accurate. Right. Intuitively, it doesn't necessarily make a lot of sense. But, if it works, but again, certainly only on some people. I also have patients who are on CPAP and have trouble with mouth venting. In other words, the air goes in here, comes out in the nose, comes out the mouth. So we use chin straps or full face masks or something like mouth tape. So that's another use for the mouth tape. So, but again, if somebody says, gee, I want to try these things, say, try the CPAP.
Especially for that patient that I just described of like a AHI of 100.
Oh my God, I wouldn't do anything but CPAP or a tracheostomy. Those are the only things that would probably work with this guy.
I think is also the idea of the mouth tape that you're sort of bringing in the airway behind the tongue. I mean, does that make sense? Or help me understand.
I mean, if you're able to, you might actually remember
that part of the cadaver lab.
You might be decreasing the resistance of the upper airway. I don't know exactly how, but I suspect that's got to be what's going on. Because the instability of mouth breathing, where the tongue can be here, there, and anywhere, you're just not guaranteeing airflow. But the upper airway itself is very narrow, as you know. I mean, just millimeters. And it has to be because our upper airway has three functions. We have to speak, or phonate, I should say. We have to breathe, and we have to swallow. And in order to do all those things and not interfere with the others, for example, if you're swallowing and you aspirate down into your lungs, not a good thing. So there are a lot of very amazing mechanisms that prevent this. So as a result, upper airway resistance by definition is going to be high. So that's why humans in general are at risk for obstructive sleep apnea because because of our upper airway resistance. There are some interesting sort of what's the word, anthropological, evolutionary thoughts on that too, but I'll leave that for another day.
You mean like the Weston Price, how our mandible and maxilla developed and how our jaws sort of narrowed over time? Are you talking about that kind of stuff? Or?
I'm talking about that, but also in terms of the sinuses and such, in that as we got smarter, our brains got bigger, and therefore our calvaria got bigger, right? Our heads got bigger.
Right.
But at some point, you're not going to be able to have that much more of a large head. Otherwise, you'll lose that survival advantage because you can't hold your head up, right? So we lost, we sacrificed space in our upper airways, like in our nasal passages, our sinus system, and all that. So that's part of it. That's sort of my understanding of it. I think it's just neat.
You know, I haven't gone into depth about this, but I know the folks from the Weston A. Price are you know, they think that our mastication, our sleep, and the nutrients really affect the sort of our maxillary development. And, you know, there's all these ideas about how our food has sort of shrunken. You know, I have that same lower jaw that's sort of retracted, you know. And there's a lot of, you know, a lot of people in the world right now thinking about how to sort of undo some of these things. And a lot of it, and to me, at first blush, sounds like magical thinking, being able to restructure your anatomy, change your palate, you know, push your tongue against your maxilla, you know, mouth tape, you know. But it's certainly interesting to me to at least ponder and consider about. But I think, you know, to your point, when you're sitting in front of that patient who can't keep their eyes awake and he drives a truck, you know, you're thinking about how do I get air into this guy's brain like right now?
Yeah.
And the easiest and quickest way to do that is the CPAP.
Yeah, it really is. And even if it doesn't work perfectly, at least it's a start of something. If you get their AHI down from 120 to 40, you know, you're doing them some favors. But I have to throw this one other alternative to sleep apnea since you brought it up. And since I'm also a wind musician, there's a musical instrument called the didgeridoo. Are you familiar with that?
Yeah, the big long, like.
Yeah, exactly.
Yeah.
And it's really hard to play because it's just, you know, it's a really large bore tube. And in order to blow into it, you're blowing against real, you know, like no resistance. So you lose your breath very quickly. So there's a technique called circular breathing, which you need to develop playing the didgeridoo. It's basically as you're exhaling, you're actually also, with your mouth, you're inhaling with your nose and storing the air in your cheeks. And that's a technique that people use for the didgeridoo. And there was a study at a British medical journal, maybe 15, 20 years ago now, where they had people with mild to moderate sleep apnea, and they had them learn to play the didgeridoo. And their sleep apnea significantly improved because they were training, yes, good answer. They were training their upper airway muscles.
For the listener, my eyes perked up, you know?
Yes. And when I saw that, I just cracked up.
What was the, can you give an idea of the magnitude? Like, I just want to get a sense of that because
I don't recall what the improvement was, but it took mild and put them into normal.
Wow.
And pretty much everybody had some improvement in their symptoms. And I actually have two patients who were didgeridoo players. And one of them I saw about a month ago, and he was really struggling with the CPAP, and he had mild sleep apnea. He said, you know, Doc, I think I'm just going to go pick up my didgeridoo again. All right, I'll see you in a few months. Seriously, you can't make this stuff up, you know?
You know, so I think, but that's hope, right? Like when you know, like, because you're treating them with convention, but you've also studied enough and were curious enough to know, hey, wait a second, you don't need an Inspire device, you know, necessarily. Like you can go play a wind instrument, you know, you can train
Yeah.
to do this, besides just weight loss, there's other things you can do. Maybe mild mouth taping, maybe didgeridoo, when instrument playing, changing the musculature, protruding the jaw with a device. These are all, it's important, right? I think a lot of times, in medicine we can get pigeonholed because there's a guideline and a standard, but sometimes these little bits of information are all somebody needs, like to be empowered. Like, wait a second, I could play the didgeridoo and I can put a mouth tape and this gets slightly better. I'll try it out, like in the appropriate patient. Certainly you wouldn't want the severe sleep apnea truck driver to be considering using that as the only only measure.
Hey, Tro, have you heard about the study? I think it was about a year and a half ago now, Malhotra and others, and it was Zepbound, tirzepatide to treat obstructive sleep apnea and obesity. Are you familiar with that at all?
Yeah, I am familiar with it.
And basically, it showed that you help people lose weight and their sleep apnea gets better, is the bottom line. And I just wonder what your thoughts are on it. My thoughts are, on one hand, it's bringing sleep apnea patients to life. On the other hand, it's, again, the mindset of relying on GLP-1, GIP receptor agonist to be the end all. So I have patients coming with me for the sole reason that they were referred because insurance did not approve their GLP-1 and they wanted to establish a diagnosis of sleep apnea so they can get it approved. They didn't want to treat their sleep apnea necessarily. So this is what makes me pull my hair out. So let me ask you, how should I approach these people without throwing something at them? Sorry.
Yeah. So I think understanding the patient goal is very critical, right? Like, and that's hard. Like, and just asking it is so critical. Like, what is your goal with my care? Like, what is it that you really want? Like, just be honest with me so I can serve you better. And if it's like, look, doc, I just need this diagnosis so I can tell the insurance company I have this so I can get this thing because that's what I want. Right? Well, let's all be clear. Let's all be clear. Like, I can help you do that because it's fairly evidence-based. Okay? And there's strong evidence. But my preference is to actually help you not need this. So whether I get it approved I'll get it approved for you. Fine. I'll prescribe it. I'm going to tell you all the side effects. I'm going to tell you all the issues with it. I'm going to walk you through, the problems you've thought and some of the problems that we have yet to fully elucidate. The eye issues, the gastric issues, the pancreatic, thyroid, that's gone back and forth. Now they're taking it off the label. So, but the thing is why are you here? Do you want the drug because you think your life's going to be healthier and that's the only way? Do you want the drug because you have nothing else you can do right now and you know it, right? Because your life, wherever it is, you can't put behavior change together, So I think just being honest, like if somebody's like, look, I will not put the effort into lifestyle right now, and I just want to buy myself time and fix these issues. I think, like, you have to, it's shared decision making. Okay, well, when you're ready, I want to help you come off that.
Yeah. Oh, I like that. So the other side of it is that
you got me riled up, that's a hard, nuanced question,
The patients will, they're being referred by their medical
well, how do you handle it? I'm curious how you handle that.
I basically say, okay, I like your thought of I can help you get off it. I like your thought of their alternatives, but I don't say that to my patients because, again, they're referred by our obesity medicine specialist. So I don't want to step on toes in that way. And you can argue against that approach. That's all you want. That's fine. But what I tell them is that, okay, that sounds good. What are you doing eating wise? And again, because this is a sleep thing, this is not a metabolic health visit. And I just, and you know, they may tell me I'm going to the gym, which is a common answer, right? And they may tell me that they're not eating red meat or whatever. I'll say, okay, well, what about your carbohydrate intake? And I'll ask them that. Because it's been my experience that it's really carbohydrate intake that may cause many of the side effects of the medication and may make it hard to lose weight. So I sort of, in a sideways way, just sort of put that to, that's really all I do in those cases. So.
Yeah, I think it's a challenging situation. You know, one of the issues in medicine is just the inappropriate and widespread lifelong use of medications, PPIs, SSRIs. You know, antibiotics are the best example because docs understand we can't inappropriately prescribe. So I think, you know, when you're looking at that through the GLP-1 realm, we have to think about, you know, how do we take holidays? How do we reapproach behavior change? How do we reapproach focusing on lifestyle and exercise? Look, these drugs cause a massive amount of lean muscle loss, up to upwards of 40%, maybe higher. The rates of weight gain are 2 times as robust and quick when you stop them compared to lifestyle. So, bottom line is, I think you know, we just have to do better as a profession. That obesity doctor needs to make sure he's talking to those people about, you know, the side effects of that drug. And it doesn't mean a drug can't be used, right? Like there's inappropriate prescriptions for any class, right? So, you know, how do we use drugs when needed appropriately and then discontinue them when no longer needed and inappropriate? These are all the considerations, you know, and I'm in agreement with you. It's like, hey, did you know there's these other simple things? Like you can have steak and eggs and bacon and lose weight. Like, gosh, like, you know, that'd be great. You know, you don't need to do the shakes. Why don't we spend a little bit of time, speaking of steak, eggs, and all the cholesterol that causes, and the bacon and all the cholesterol that causes, maybe we could just briefly talk about this documentary that you and I were going to support by going there and answering questions and doing a Q&A after the fact. You know, we're really trying to mobilize our communities to support this and just watch it. It's a different perspective on cholesterol. It's called the Cholesterol Code. And it was produced by an amazing group at Wide Eye with Jennifer Eisenhart, and just on a great group that also brought Fat Fiction and other movies together. And the lead star is Dave Feldman, you know, who's
truly a star.
who's done a lot in the space, you know, from challenging the status quo to running clinical trials and continuing to run clinical trials. So I'm interested. Have you seen the movie yet, or you know, you just saw the screen, the little teaser?
I saw the trailer. Right? Yeah, I haven't seen the movie, and it's just like, you know, for me, I'm really grateful that I didn't do any blood work until after I had seen Dave Feldman speak for the first time. Because if I saw those numbers of my total cholesterol 315, my LDL 215, I would have ignored my HDL and triglycerides in the 80s. I would have freaked out. And but I already knew about the LMHR phenotype. So so again, personal experience. And, you know, as you know, I've had several coronary artery calciums, and with those high LDL numbers, presumably since I started eating like this in 2008, so 18 years, and my most recent coronary artery calcium score was 0, right? So just like all of them have been dating back to 2018. So I, again, personal experience, understanding it, getting the science, and seeing that our practices as a profession, our advice we're giving patients as a profession, is really not necessarily the right advice, right? And so I'm feeling very strongly about the work that Dave and his group are doing, and that this documentary comes out, and I have the opportunity to see it, right around the corner from my home, is really exciting for me, and I'm really looking forward to that. And it's going to be at the Galleria in Middletown, April 22nd at 6 p.m. And can we give people the link, Tro?
Yeah, absolutely. We're going to
Yeah,
put the link in the show notes, and I'm going to publish it on social media that are out there. We're going to put it in the chat. So you
great.
know what? If you're in the Toward Health app, actually, that link is already there. It's going to be listed there. And if you're on, the social media, it's going to be on. If you're on joining us from Twitter, it'll be right underneath the thing. And if you're in the New York area, just sign up. You got to reserve a ticket. We need certain amount of people to come so that we can do this. If you're in the Toward Health app, it's going to be listed as an event. And if you're out there listening, just so you know, this is there's also going to be another sort of amazing person that's going to be there. It's going to be Nina Teicholz. So you'll get two metabolic docs and a metabolic health juggernaut, I would say, will be there. She's the author of Big Fat Surprise, and she was the executive director of the Nutrition Coalition for many years, and a huge force behind the new guidelines, new dietary guidelines. So Nina Teicholz will be there, myself, Dr. Alan Schaffer will be there, and there's a chance that I hear that Dave Feldman may be around. So I don't know that that's finalized, but there's a chance. He'll certainly be there on the screen, but there's a chance he may grace his presence as well. So if the three of us weren't enough for you. So just check out, if you're joining us live from Twitter, I see there's 500 people live from Twitter. Just go underneath on the post here, and you'll see the link there. If you're on the Toward Health app, it's posted there already underneath this, and you can join in. It's listed as an event that you can join, and it's in the Hudson Valley area in Middletown. And it's a Wednesday. What was the date? It was the 22nd.
The 2nd of April, April 22nd at 6 p.m. And the movie is 1 hour, 40 minutes. And I've been thinking about afterwards, I have to go look around the mall and see where a good place to be, where to sit and chat, and maybe have a little something to eat, or maybe at a local diner. So I was planning on offering anybody who signs up to get together after the movie so we can talk about it, because I would hate to see such a movie and then not have anybody to talk to about it. So I'm going to set that up, and Tro, you, Nina, Dave, anybody who's there. I know you guys live far away and I don't expect it, but I'm planning on just sort of, I'm sure Christy, who's hosting it, will be glad to participate as well. So I'll let people know the details probably the night of the screening about where we might meet.
Yeah, I think that sounds awesome, and I'll certainly be there, because my trip isn't all that far. But I think we are gonna have some questions, a Q&A right after in the auditorium. I'm not positive, but then absolutely I will be at that meal. My wife will be there, so we'll all join. Hopefully there's some good steaks wherever we decide to go. So if you're listening, if you're out there, it's not just a screening and then go home. We'll certainly be hanging out afterwards. Dr. Alan Schaffer will be there for questions, and I will be there for questions, and Nina Teicholz will be there for questions. And then right after that, we'll go to eat. Because certainly many of us will not be doing the palm oil and popcorn that is typically served in those areas. But so I'm excited about it, and I hear that I'm in the movie apparently. So
you're right there on the trailer, yeah.
Yeah, I am in the movie, and so I'm excited I've seen it. It's a good movie. You all should watch it. Thanks, Dr. Alan Schaffer, Alan, for setting this up. If it wasn't for you, I don't know that I would have gotten to doing this. So I appreciate you prodding me and sticking with me, and spending your Sunday morning here talking about metabolic health, sleep medicine, obesity medicine, and really
no better way to spend my time, to be honest with you.
That's really bad if you and me are the best it gets on a Sunday,
Oh, come on.
Yeah. All right, Alan. But thank you to everybody who's listening, everybody in the Toward Health app, social media. I appreciate your all help, and go support Dave Feldman and Wide Eye Productions, and support this documentary. It takes a monumentous effort, so any bit of support helps, and that link will be in the show notes. And come join us, and you get to see Nina Teicholz. I mean, I'll pay $17 just to see Nina, All right. Thanks again, Alan. And we'll put your information if there's a patient in the area that is interested. We'll have your information at your practice right there, and how you want them to reach out to you.
Absolutely.
All right.
Great.
Thanks a lot.
Thank you, Joe.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.